Welcome to the body imaging cases. This is a case of a mentally retarded young lady who became suddenly agitated and had self-inflicted injuries of her hands and face. In view of the difficulty of history taking and the difficulty of clinical examination, pan-CT of the head, neck, chest, abdomen, and pelvis was performed. The abdominal CT shows free intra-abdominal fluid and gas, denoting hollow viscous perforation. It shows also an intragastric foreign body composed of concentric layers of high and low attenuation value entrapping gas. This appearance is typical of trichobezoar, the term given to ingested hair. On asking the family specifically about that, they admitted that the young lady used to ingest textile fibers taken from detached parts of the house carpets. The common feature between hair and the textile fiber bezoar is that both tend to clump together, forming a mass, casting the shape of the stomach and having sort of a tail that extends into the duodenum and even the jejunum without being separated or migrated into the small intestine, unlike other types of bezoar which do not stick together to the same degree and can detach, leave the stomach, and migrate to the small intestine to cause intestinal obstruction. Example of this is, of course, the phytobezoar made of indigestible plant products. Here there is discontinuity of the gastric wall, denoting one site of gastric perforation at the greater curvature. And another site of perforation at the lesser curvature. This section shows the continuity of the bezoar into the pylorus. And duodenum. And the jejunum with marked thickening and enhancement of its wall. There has been no collapse of the colon. Therefore, the dilatation of the ileum seen here is probably due to ileus caused by peritonitis rather than mechanical small intestinal obstruction. The minimum intensity projection makes a very good use of the gas entrapped within the textile fibers to delineate the continuity of the textile bezoar in the stomach, duodenum, and its tail at the jejunum, without any part of it detached. The colon contains fecal matter which is in favor of ileus and not mechanical obstruction as the cause of the small intestinal dilatation. And here we have two sites of gastric perforation delineated by the gas, one at the greater curvature and one at the lesser curvature. The patient has been operated, the textile bezoar removed, the gastric perforation closed, and the peritoneum lavaged and drained. Diagnosis is gastric perforation and peritonitis due to textile bezoar. The learning points are: textile bezoar is rare but can be encountered in mentally retarded patients. Textile bezoar may look similar on imaging to trichobezoar, appearing as a foreign body inside the stomach composed of concentric layers of high and low attenuation values entrapping gas and extending in continuity into the duodenum. Bezoars that tend to stay in the stomach as one mass, by virtue of their entangled filaments, are more likely to be complicated by gastric perforation, and the examples here are trichobezoar due to ingestion of hair and textile bezoar. On the other hand, bezoars that do not entirely hold together tend to detach and migrate and cause intestinal obstruction, and the best example is phytobezoar.